Hi class, welcome to the recording of the Psychotic Disorders lecture. My apologies for not being able to hold class yesterday. I'm still getting over a cold and I was not feeling very well. So this will take place of the lecture that was supposed to happen on Monday, January 23rd. All of this material will still be required information to know for quizzes or exams. Please, if you have any questions, post them on Blackboard or don't hesitate to shoot me an email. So we don't need Turning Point. Again, the suggested reading, I think I went over this in the pre-lecture, is DePiro, and then suggested viewing is the TED Talk by Ellen Sachs called The Tale of Mental Illness. And I posted a couple other videos on Blackboard too. For the lecture objectives that we'll cover, by the end of this recording, you'll be able to hopefully do the first 3 objectives because those were pre-lecture material, and then by the end of this recording you'll also be able to describe how receptor pharmacology of antipsychotics may relate to their observed and adverse effects. You'll be able to recommend pharmacotherapy to treat psychosis, and you'll be able to list relevant therapeutic outcomes and monitoring parameters for antipsychotics. So the first question, based on the pre-lecture material, is we have Roger. He's a 42-year-old male with a history of schizophrenia. He called his mother yesterday and said, "I built a room that's going to protect me. It's metal. It's sitting in the living room. I can lock myself inside so the satellites won't be able to track what I'm doing anymore. I can be safe inside of it." And this is an example of what schizophrenia symptom. So this is actually a delusion because he has a fixed false belief that satellites are tracking what he's doing. This is not a hallucination because we don't have any evidence to say he's attending to internal stimuli such that he says he's hearing voices or seeing things or anything like that. We can follow what he's doing, so it's not, or what he's doing and thinking based on this little excerpt, so it's not disorganized speech. And it also doesn't really reflect negative symptoms because he's talking to his mother, and it doesn't say anything about him, not engaging with loved ones, family members, having like no affect, reduced mood, those kinds of things. Question 2, how would you describe the difference between schizophrenia and schizoaffective disorder? So for this one, I just included the drawings from the pre-lecture material. The way to summarize this is, with schizophrenia, schizoaffective disorder, you have psychosis present the whole time. But with schizoaffective disorder, you have mood states on top of the psychosis. So with depressed type, you have depressed mood states on top of the psychosis. But even when somebody isn't in a mood episode or a major depressive episode, they also still have psychosis. And then for schizoaffective disorder bipolar type, they may have hypomanic states or depressed states or full-blown manic states, all with psychosis. But also when they're not in one of those mood episodes, they still have psychosis. Whereas with schizophrenia, you don't have these discrete mood episodes on top of psychosis. Question 3, which of the following neurotransmitters has not been associated with schizophrenia? And the answer to this is norepinephrine. This is based on the pre-lecture material where there was a slide that listed a bunch of neurotransmitters that have been identified to be associated with schizophrenia, but norepinephrine was not one of them. Abnormalities in which of the following dopamine pathways can cause significant movement disorders. So knowing which dopamine pathways have which effects is going to be an important part for this lecture, and important to know what effects antipsychotics have on different pathways. And so I will expect you to know the different dopamine pathways. And so the dopamine pathway that causes significant movement disorders is the nigrostriatal pathway. And then the last question on the pre-lecture material is, which of the following first-generation antipsychotics is also indicated for nausea, vomiting, intractable hiccups, and tetanus? And that's chlorpromazine. It has a whole bunch of FDA-approved indications, whereas the others don't have as many. So for treatment approaches, the things we like to think about are, what are the goals of treatment? And there's different goals depending on the stage of treatment that you're in. So if you're in the acute setting, that is, somebody has just had a psychotic break or is at an acutely psychotic episode, there are a few things that we really need to hammer down, and that is first, to reduce threat to self and others. We really want to make sure that people around the person with psychosis and the person with psychosis themselves are not at danger, at any sort of danger. We also want to reduce acute symptoms. We want to reduce agitation, reduce hostility, reduce anxiety, and reduce abnormal sleep that may come up. And then we needed to develop a treatment plan moving forward. For the stabilization phase, you really want to prevent relapse into the acute phase again. And then you also want to optimize the med regimen. This may mean a dose change. This may mean trying to minimize adverse effects that the person is experiencing. And then follow through with a monitoring plan for whatever medication they might be on. And then in the maintenance phase, you'll also want to be preventing relapse and then trying to increase the person's functioning as well as their quality of life. And then for monitoring, you'd be monitoring for any sort of prodromal symptoms. So that's symptoms that might tell us that somebody's at risk for having another acute psychotic episode, as well as trying to monitor, trying to monitor for adverse effects. So with schizophrenia and schizoaffective disorder, there are several non-pharmacologic treatments that are available. However, these really are not supposed to be a mainstay of treatment. It is fine for somebody to be involved in them, but these are supposed to be in addition to, as the box notes at the bottom of the slide, in addition to, as opposed to in lieu of antipsychotic treatment. So these are really just for your information to let you know that there is non-pharmacologic options available. However, they are not considered the mainstay of treatment. The mainstay of treatment is antipsychotics. And so this slide shows that we have a whole bunch of antipsychotics. There are first generation antipsychotics, which are considered the older antipsychotics. They've been around for decades. And then we have the second generation antipsychotics, which are quite a bit newer. Some of them are still coming out onto the market. And we'll talk about these and compare and contrast them separately. So with the acute phase, this usually is somewhere between 1 and 2 weeks of somebody having an onset of psychotic symptoms. This is when you want to start antipsychotic therapy. You'll want to titrate the dose over the first few days as the person tolerates to what you would expect to be an average effective dose. After 1 week on a stable dose, which you would consider maybe a modest dose increase if the original target symptoms are still around. And just to know, I'm not going to expect you to know like specifically how to titrate all of the individual medications. There are a few things that we'll go over specifically, but I don't expect you to have an idea of exactly what you should be doing while the person's in the hospital in the first couple weeks of their acute psychotic episode. But the other thing to consider is that there are liquid preparations that could be used for patients that are suspected of if they're like maybe cheeking their meds so that they're not really swallowing them and they just pop them in their mouth, stick them in their cheek until the nurse runs away and then they spit them out because they don't believe they should be taking them, which we tend to see sometimes in the inpatient settings. Or if patients have difficulty swallowing, then you could use the liquid preparations. So then the stabilization phase is the next 3 to 4 weeks. Sometimes this is still continued in the inpatient setting because you still really need to make sure that the person's okay. However, if somebody's maybe not in such a severe psychotic state, then they may be discharged from a hospital and the stabilization phase could occur on the outpatient basis. So if the person responds to the initial antipsychotic treatment without any adverse effects, you could continue that antipsychotic without any changes. If the person has only a partial response at what we would expect to be a therapeutic dose, you'd want to assess, there's a few things you want to consider. First is to consider whether or not the patient's actually taking the medication. So this would be in the case of, in the inpatient setting, maybe they're cheeking their meds, or if they're in the outpatient setting, whether or not they're taking their meds at all. It might also be time to titrate the dose. Maybe you're at a low end of a therapeutic dose. And so you can continue to increase it further to see if you get more response. You could also consider adjunctive medications, especially if the person has other comorbidities. So like maybe they have, if it's schizoaffective disorder, depressed type, you may want to add an antidepressant to try to help them with their mood. You could consider switching to alternative antipsychotic if the partial response really is not showing to be is really insufficient, and it seems like adding something else on, or it really wouldn't help that much, and changing a whole other treatment might be better. And then the other alternative is to consider combination treatment, which would be to combine two different antipsychotics. We usually don't recommend dual antipsychotic therapy. However, we do tend to see this pretty often in clinical practice, even though it is definitely considered not a gold standard and is not recommended. If you don't have any response at all at a therapeutic dose of an antipsychotic, really want to consider poor adherence. Maybe the patient's just really not taking it at all. If it's definitely true that the patient is taking it, you really want to change the antipsychotic because they're just not responding to that one at all. And you could consider the possibility that they have treatment-resistant schizophrenia or schizoaffective disorder. After the stabilization phase comes the maintenance phase, which should be lifelong. However, we tend to see that patients with psychotic disorders tend to wax and wane in their ability to maintain treatment forever. Remember that the treatment goal in the maintenance phase is to prevent recurrence or relapse of symptoms. Antipsychotic medications can reduce the risk of relapse to less than 30% per year. So they're really effective and they really do help people. One of the big problems is that a lot of times patients don't trust that the antipsychotics are helping them or that they're good for them, and they don't. Sometimes there's still some of the paranoia, and patients don't believe that they should be taking the medications, and so that can very often kind of wreak havoc on the ability to have a successful treatment. But ideally, in the maintenance phase, you would continue on the same regimen used for acute stabilization, and need to consider that symptoms may continue to improve for up to 3 to 6 months. So while somebody gets admitted to the hospital and is in their acute phase and they're acutely psychotic, their symptoms may begin to improve when you start antipsychotic treatment. However, those symptoms will continue to improve even after you've gone through the stabilization phase and into the maintenance phase. Those symptoms should continue to improve over the next 3 to 6 months. So if you're facing a patient with a relapse or recurrence of symptoms, there's a few questions you want to ask. First one always is, was the patient adherent? So were they actually taking their medications? You also want to ask, how does the patient's current status compare with previous relapses or recurrences, and what happened at those times? So is the presentation that the patient has right now very similar to presentations that the person's had before when they weren't on any medications or were acutely psychotic for other reasons? And you also want to think about whether or not we have the correct diagnosis. So again, this kind of relates back to if you have the incorrect diagnosis, then you could be using the incorrect treatment, and that's whatever the illness is not going to respond to the incorrect treatment. So those are just some things you need to consider when somebody presents in the case of a relapse or a recurrence of symptoms. So another question. For a 21-year-old female just admitted to the hospital with florid psychosis, which of the following represents a current goal of treatment? Would you want to A, optimize the medication regimen, B, reduce threat to self and others, C, prevent relapse, or D, increase functioning and quality of life? So this is an acute setting, and so for this situation, one of the main goals of treatment is to reduce threat to self and others. So we'll next get into the actual medications that we use to treat psychotic disorders. We'll first start with the first generation antipsychotics, or FGAs. These are also known as typical antipsychotics or conventional antipsychotics. So the way that they work is you tend to see that they predominantly work by antagonizing dopamine D2 receptors. This will reduce mesolimbic dopamine activity, which then causes a reduction in positive psychotic symptoms. So this will cause a reduction in delusions, hallucinations, and disorganized behaviors and thinking. all of the first-generation antipsychotics will reduce positive symptoms with about equal efficacy. We don't really see that certain first-generation antipsychotics work better or worse than others. So what happens when you have this potent, or if you have potent dopamine D2 antagonism, is all of the different dopamine pathways are affected. While we're targeting the mesolimbic pathway, which is the blue pathway, to reduce positive symptoms, we also see that we end up inhibiting or blocking dopamine activity in the other three main dopamine pathways. So when we block dopamine activity in the mesocortical pathway, we actually have an increase in negative symptoms and cognitive symptoms. When we block dopamine in the nigrostriatal pathway, we see movement disorders. And when we block dopamine in the tuberoinfundibular pathway, we see an increase in prolactin release. So the general approach that we take when dosing first-generation antipsychotics, for the most part, haloperidol tends to be the most commonly used first-generation antipsychotic. It's definitely very commonly used in the inpatient setting when people are severely agitated or have delirium. And we see with haloperidol that sufficient D2 or dopamine D2 receptor blockade is achieved with relatively low doses of haloperidol, only 2 to 5 milligrams. In the acute setting or in acute psychosis, antipsychotic dosage typically gets increased until the person's behavior improves or their adverse effects limit the dose. First-generation antipsychotics are typically dosed 2 to 4 times a day for the first 1 to 2 weeks. And we do that to limit adverse effects. So we'll spread out, we'll kind of like divide up the total daily dose and spread them out throughout the day. And then after the first couple weeks, when we see that the person's tolerating it, we then will consolidate it to bedtime dosing. Intramuscular and IV antipsychotic formulations are 2 to 4 times more potent than oral formulations, and they really should be limited to the treatment of acute psychosis. There are depot intramuscular options available, and so what that means is that it's a shot that's given once every somewhere between 2 and 4 weeks, and that will allow for the person to not have to take an oral dose all of the time or every single day. So there are these options for fluphenazine and haloperidol. So all antipsychotics come with a pretty wide variety of adverse effects. And we see that the first-generation antipsychotics have several adverse effects that are pretty customary to them. There were, I had you guys look at a lot of them in the pre-lecture material, and there's that one slide that shows kind of the spectrum where you have low potency antipsychotics or first-generation antipsychotics that have low potency at the D2 receptors versus some antipsychotics that have moderate potency and then others that have high potency at the D2 receptors. And based on the potency at the D2 receptors, you then have or would expect different types of adverse effects. The thing to remember is that even though we wouldn't expect to see effects of a high potency antipsychotic, like let's say extrapyramidal symptoms, which we'll get into, even though we wouldn't expect to see extrapyramidal symptoms with a low potency antipsychotic like chlorpromazine, it's still a possibility that we would see them. And so the point of this slide is to show you that all of the first-generation antipsychotics have potential to cause any of the listed adverse effects. It's just that we expect to see certain adverse effects more likely in certain medications. So with a high potency antipsychotic like haloperidol, we would expect to see extrapyramidal symptoms quite a bit more. And then with a low potency first-generation antipsychotic like chlorpromazine, we expect to see things like metabolic side effects a bit more, like type 2 diabetes. When it comes to extrapyramidal symptoms, this is broken up into 4 main components. First one is pseudoparkinsonism, and we'll go through these in the next slide. The next one is akathisia, the next one is acute dystonia, and then we have tardive dyskinesia. So, with extrapyramidal symptoms, like I said, we really expect to see these most commonly with the high potency first-generation antipsychotics. And these do tend to be dose dependent, so the higher dose you give, the more likely you would expect to see the extrapyramidal symptoms. The onset typically is within only a few weeks of starting treatment or after a dose increase, except for tardive dyskinesia, which we'll talk about in a couple slides. For pseudoparkinsonism, that looks like movement disorders. So it really looks like somebody's developing symptoms of Parkinson's disease. So they'll have the rolling tremor, there'll be slow movement, bradykinesia, a shuffling gait. You'll also see cogwheel rigidity. We know that pseudoparkinsonism is reversible with a dose reduction, or if you add an anticholinergic agent like benztropine. Akathisia is another extrapyramidal symptom. This is when patients will report some sort of inner restlessness. They may be pacing, they may have a tough time sitting still. They'll just feel like they can't stop moving. This is also a reversible adverse effect that we see if we reduce the dose or we switch the antipsychotic to a different antipsychotic. Another extrapyramidal symptom is acute dystonia, which can be much more severe and serious. These are spastic muscle contractions. They can happen in various parts of the body. Sometimes we tend to see it more common in the neck, where the person's neck is kind of bent backwards. This can be life-threatening if it's untreated. It usually requires the administration of intravenous or intramuscular benztropine or diphenhydramine, which we're trying to use their anticholinergic effects to block the effects of that acute dopamine blockade. So if somebody does have acute dystonia, like I said, you would give IV or IM anticholinergic agent. So benztropine would be 1 to 2 milligrams. Diphenhydramine would be 50 milligrams. For milder cases, it doesn't seem like it's a life-threatening case, you'd give oral benztropine 1 to 2 milligrams daily, up to once a day or twice a day. These medications should be continued until the symptoms resolve. However, if the symptoms come back when you stop the medications, then you restart them and continue indefinitely. So, like I said, tardive dyskinesia is the third type of extrapyramidal symptom, and this one tends to be significantly more serious, and one that this is basically the reason that we don't use first-generation antipsychotics long-term anymore, or if we can avoid them, then we do avoid them. We see tardive dyskinesia typically after long-term antipsychotic treatment. It is potentially irreversible, so once the symptoms come on, even if you change the agent or you add an anticholinergic agent, it is hard to make those symptoms go away. The symptoms look like myoclonic jerks, so those are like jerks of the limbs, like arms and legs. They may look like tics, movements of the face. Typically, a lot of the movements involve the face and the mouth. Chorea, which is specific, it's a certain type of movement of the arms. And dystonia, like I was talking about with acute dystonia, you also see that in tardive dyskinesia. There is a video that I posted on Blackboard. I would have shown this in class today, but I'll spare everybody from watching it during this recording. But there's a video that's posted on Blackboard, and it's an example of tardive dyskinesia. I highly recommend watching it. It's only 3 minutes long, just to get an idea of what it actually looks like when somebody has it. Risk factors for developing tardive dyskinesia are long-term, high-dose, high-potency, first-generation antipsychotics. Also, people are elderly or of the female sex. And then we also are more likely to see tardive dyskinesia, interestingly, in patients that have other affective disorders. So that is like people who have so if they have schizoaffective disorder and they have either depressive type or bipolar type, if they have other types of mood disorders on top of their psychotic symptoms, then we're more likely to see tardive dyskinesia. The treatment for tardive dyskinesia is to discontinue the antipsychotic that they're on and switch to one with a lower risk of causing extrapyramidal symptoms. However, we don't really have great evidence showing that this actually improves the symptoms. But it's basically the only thing we can do in hopes of not making anything worse. So, to summarize long-term risks and benefits for first-generation antipsychotics, the benefits of them is that they do reduce the positive symptoms, and the efficacy often continues after an extended treatment period. So if you stop treatment if somebody's been on haloperidol for a couple years and then you stop it, their efficacy actually tends to continue for months later. However, the risks are that the side effects can be intolerable or unacceptable to a lot of patients or the patient's family members. We do see a frequent discontinuation rate because of side effects. And because of that frequent discontinuation rate, we're likely to see a high relapse risk because people tend to just stop taking their antipsychotics. So another question. A 54-year-old male presents to the emergency department making unusual movements with his mouth and neck. His wife tells the triage nurse that he has schizoaffective disorder and was just started on a new medication, which was flufenazine. What's probably happening to this patient? Is it pseudoparkinsonism, akathisia, tardive dyskinesia, or acute dystonia? So this one's a little bit tricky. It could be tardive dyskinesia, even though we said that tardive dyskinesia tends to happen much later after somebody's been on an antipsychotic for quite some time. But I would say, so I know that I have the block arrow out over tardive dyskinesia, but really the answer could be either tardive dyskinesia or acute dystonia, because he is, I think what I was thinking with the tardive dyskinesia is the unusual movements with his mouth and neck. If he is making these movements and he's not actually like stuck in a certain position, that more looks like tardive dyskinesia, whereas acute dystonia is typically when somebody's kind of in an odd posture and they're kind of like stuck in that position. However, either of these answers could have been correct. So next we'll get into a review of the second generation antipsychotics, and these are also known as the atypicals or the atypical antipsychotics. So if you'll remember the effects of potent D2 antagonism, we see that while they do reduce positive symptoms, potent D2 antagonism does reduce positive symptoms through the mesolimbic pathway. Through the mesocortical pathway, it increases negative and cognitive symptoms. It causes movement disorders, and it increases prolactin release. So what we would like to do is keep the reduction in positive symptoms, so keep the dopamine blockade at the mesolimbic pathway. We do want less dopamine activity in the mesolimbic pathway, but we want normal or more dopamine activity in these other regions of the brain. So in the tuberoinfundibular pathway, in the mesocortical pathway, and the nigrostriatal pathway, ideally, we wouldn't be affecting dopamine so negatively in those pathways so that the person could have more normal dopamine output and have less risk of all of the adverse effects that comes along with potent dopamine blockade in those pathways. So ideally, with second generation antipsychotics, so if we were able to create the perfect second generation antipsychotic, we'd have one that potently blocks dopamine in the mesolimbic pathway to reduce positive symptoms, one that doesn't cause significant dopamine blockade in the mesocortical pathway so that we have a reduction in negative and cognitive symptoms, one that doesn't affect dopamine at all in the nigrostriatal or the tuberoinfundibular pathways so that we have decreased risk of movement disorders and normal prolactin release. So just to kind of give you an overview of the approach to take with second generation antipsychotics and what a certain way to kind of think about them. In general, the SGAs are thought to be associated with lower overall risk of extrapyramidal symptoms compared to first generation antipsychotics. They're also thought to be more effective in treating the negative psychotic symptoms, so the things like low mood and the cognitive effects. However, in clinical trials, we don't actually see that they're necessarily that effective in treating those symptoms. The mechanisms of action of the different second generation antipsychotics vary pretty widely. We have serotonin 2 receptor and dopamine antagonists. We have dopamine D2 antagonists that have a rapid dissociation from the D2 receptors. We have dopamine D2 partial agonists, and we have serotonin 1A receptor partial agonists and serotonin 2A receptor antagonists in the mesocortical tract. So, the first category was the dopamine and serotonin 2A antagonism. So this is a common mechanism of action for most of the second generation antipsychotics. The extent of the antagonism is different between the different agents, but we don't need to really get into that for the purposes of CDM4. This activity allows for targeted dopamine antagonism in the right area. So the areas that we want dopamine antagonism, we have dopamine antagonism, and in the areas we don't want it, then we don't have it. This also allows for normal prolactin release, which is the result of not decreasing dopamine release in the tuberoinfundibular pathway. So then, while the dopamine and serotonin 2A antagonism is an effect of most of the second-generation antipsychotics, there are other antipsychotics that have specific effects at specific receptors. And so clozapine and quetiapine are the only two agents that have D2 antagonism with rapid dissociation. So what happens is that clozapine and quetiapine will stay on dopamine D2 receptors long enough to cause an antipsychotic effect, but then they dissociate from the receptors prior to causing any adverse effects. So this implies that continuous receptor occupancy is not required for the desired therapeutic antipsychotic effect. So you just have to have the antipsychotic sitting on the receptors for a certain amount of time, and then they can dissociate. You can still get the antipsychotic effect, but you don't end up having all of those adverse effects. So that's the theory behind clozapine and quetiapine, and we'll see that that comes in handy in a lot of different situations. So another group of agents are the partial antagonists at the D2 receptors, and that's aripiprazole, brexpiprazole, and cariprazine. Brexpiprazole and cariprazine are newer agents, and so I'm not as familiar with those two agents. They've been approved within the last couple of years, but they seem to have very similar effects as aripiprazole has. These agents will bind D2 receptors to cause some sort of an intermediate output. So they'll decrease D2, dopamine D2 hyperactivity in the mesolimbic and the nigrostriatal pathways, even though they don't completely inhibit D2 receptors. So this graph is really just to show you how partial agonists work, where you end up with a ceiling effect, and as you increase the dose more and more and more, you can't get additional effect beyond a certain point. So what happens is we tend to see less of the negative symptoms, or theoretically, we should see less of the negative symptoms with these agents, these three agents, because of the partial antagonism as opposed to the full potent D2 blockade, like what happens with the first generation antipsychotics. And then the final category are the serotonin 1A partial agonists and serotonin 2A antagonists in the mesocortical tract. So all of these agents, these four agents, do all of these things. And you'll notice that clozapine and quetiapine are also on this list, as well as aripiprazole. And so these three agents we also had noted in the previous two slides. So this is just to highlight the fact that a lot of these agents have overlapping mechanisms of action, and so I just have them highlighted here on these slides to show you that these are their other additional mechanisms of action and what effect that causes downstream. So because of this activity, by having the partial agonists and the antagonists in the mesocortical tract, at the serotonin receptors, it's thought to limit the negative symptoms of schizophrenia. However, this hasn't really been clinically proven, but it's what all of their the theoretical articles that have been published on these agents have said. So what happens with this activity is then you have increased dopamine release that occurs in certain areas to limit the adverse effects. So if you increase mesocortical pathway dopamine activity, you get a reduction in negative symptoms. And if you increase dopamine release in the nigrostriatal pathway, you have a reduction in the risk of extrapyramidal symptoms. And then if you also decrease glutamate release, you have a decreased glutamate at the NMDA receptors to cause a reduction in positive symptoms. And these are the effects that are seen through the serotonin partial agonism and antagonism is in the mesocortical tract. So there's a combination of various effects that happen with these four agents. Again, this is getting into the details quite a bit here, and so this is information that I really wouldn't expect you to understand or know about each individual agent. The things I would expect you to know are that these three agents, aripiprazole, brexpiprazole, and cariprazine, are the D2 partial agonists, and that clozapine and quetiapine are the D2 agonists with rapid dissociation. Other than that, you don't really have to worry about the specific mechanisms of action of any of the other agents. So for first generation, second generation agents, we have a very common adverse effect that happens commonly across all types of these agents, and that is mortality in dementia-related psychosis. So what happens a lot is that patients with dementia will develop psychotic symptoms, and they're often treated with antipsychotics. And there have been several studies that have been completed, and the FDA has done several reviews and found that we see an increased mortality in patients who are treated with antipsychotics to address their dementia-related psychosis. So just to kind of overview these bullets, there are things to remember are that there are no antipsychotics that have an FDA-approved indication for dementia-related psychosis. So even though they're used all the time for that, none of the agents actually are indicated for that diagnosis. Other thing to remember is that antipsychotics are really poorly tolerated in the elderly, especially when they're only just used for behavioral and psychological symptoms in dementia. So if somebody's just agitated and they get an antipsychotic to calm them down, the person is really not likely to tolerate that antipsychotic very well. And it's also not really an appropriate indication because the person's just agitated. It's not necessarily that they have symptoms of psychosis. But one thing to remember is that if somebody has significant agitation and aggression and maybe is psychotic, both the first generation and second generation agents can be effective, but we always need to consider whether or not they're being well tolerated. So in 2005, the FDA released a public health advisory for second generation antipsychotics after they completed a meta-analysis of 17 trials that revealed a 1.6 to 1.7-fold increased mortality rate, and most of those were from heart-related events and infections. So this led to a black box warning for all of the second generation agents. So that was in 2005. Well, then a few years later, they conducted 2 epidemiological studies that showed increased mortality with the first generation agents as well. So the FDA then requested that black box warnings be added to first generation agent labels as well in 2008. So now we have first generation antipsychotics and second generation antipsychotics all have kind of a blanket black box warning that there is increased mortality if these agents are being used to treat dementia-related psychosis. So since we're talking about black box warnings, we really need to focus a little bit on clozapine because clozapine has 5 black box warnings. While this agent is has a very special spot in the treatment of psychotic disorders, it's important that we really consider a lot of the negative adverse effects that can happen with clozapine. So the first adverse effect that most people think of when they think of clozapine is severe neutropenia. So clozapine is associated with agranulocytosis, and so it requires significant blood monitoring for the entire duration that somebody is on clozapine. This can cause serious and fatal infections if somebody has severe neutropenia. So because of this, clozapine is only available through a REMS program, which requires all that monitoring and all that blood monitoring, and it requires that the pharmacist, the prescriber, and the patient themselves all be registered with the clozapine REMS program, and the patient has to be, their file basically has to be updated continuously throughout the duration of their treatment to make sure that it's still safe to continue prescribing clozapine for that person. Another black box warning is orthostatic hypotension, bradycardia, and syncope, and this is because clozapine is actually a pretty significant alpha-1 blocker, and so you could have, kind of like when you get first dose syncope with prazosin or any other types of alpha-1 blockers, you can see that a lot with clozapine too, and it can be so severe that you can end up with bradycardia or syncope. So the greatest risk, kind of similar to prazosin, is with treatment initiation. So when you're first starting out with it, because the person's not used to having those reductions, those quick temporary reductions in blood pressure. And then it also is very risky with rapid dose escalation. And because of this reason, we actually have to start clozapine at extremely low doses and very slowly increase over a period of about 1 to 2 months. before we get to an effective treatment dose. Another risk with clozapine is seizures. These tend to be dose related, so you have higher seizure risk at higher doses. And you definitely want to take caution in patients with a history of seizures. It's not that it's contraindicated in patients with a history of seizures, but you would want to consider the risk versus benefits. The fourth black box warning is myocarditis and cardiomyopathy, which doesn't have a clear explanation as to why this occurs, but it has been shown in patients on clozapine and it can be fatal. It is appropriate to discontinue treatment if the patient is starting to demonstrate any signs or symptoms of heart disease. And then, like we just talked about on the previous slide, there is the increased all-cause mortality in elderly dementia patients. So we have another patient case. This is a 21-year-old male who presents to the emergency department, brought in by police after stopping traffic on Mass Ave. He was walking up to cars and yelling at drivers, accusing them of implanting trackers in his brain that enable the government to know where he is and what he's thinking at all times. Emergency department staff gained collateral from Joe's parents, who explained that Joe had been acting increasingly bizarre over the past 6 to 7 months. He said that he wasn't eating food that his mother would cook for him. He was sleeping excessively, alternating with pacing around the house. He started failing college courses and eventually stopped attending them. He stopped using his cell phone, but he previously used to use it all the time. And he stopped talking to his friends and family, but when he did talk, he was difficult to understand and follow. So in the emergency department, Joe's agitation was managed with lorazepam and haloperidol until he was sufficiently calm to be admitted to the inpatient psychiatry unit. On interview, Joe endorsed hearing voices telling him to hurt himself so the government could no longer track him, belief that his mother had been poisoning his food for the past year, no longer using his cell phone because it has a GPS tracker, and dropping out of school because he was no longer interested. Joe was diagnosed with schizophrenia, first acute episode. So, upon admission to the inpatient psychiatry unit, Joe was started on olanzapine, 10 milligrams daily, and tolerated it well with some sedation. Within a few days, Joe's inpatient treatment team titrated his olanzapine up to 15 milligrams daily to target additional symptoms. By the time he was discharged from the hospital 10 days later, Joe reported the voices were much quieter and were no longer commanding him to do anything. At Joe's outpatient psychiatric med management follow-up visit a month later, Joe's mother presented with him and noted he's getting more meat on his bones, but he's not doing much. Joe reported feeling very tired most days. So, if you were prescribing Joe's outpatient antipsychotic medication, what would you do with the information that his mother just told you? Would you stop olanzapine due to weight gain and start aripiprazole? Would you reduce the olanzapine dose because Joe may continue to respond to 10 milligrams daily and the side effects are dose dependent? Would you suggest Joe take his olanzapine at bedtime rather than upon waking? Or would you switch to haloperidol? So for this question, you could consider a medication switch, but before we consider that, it does seem like he's responded pretty well to the olanzapine so far. And one thing that we should try doing just first and foremost is see if he takes it at bedtime, if that helps with the daytime sedation. While he is getting more meat on his bones, like his mom said, that's actually kind of a good thing because remember, he wasn't eating anything at all. So it was okay that his appetite had been increased a bit. So next section is choosing pharmacotherapy. So we have first generation antipsychotics, we have second generation antipsychotics, but what do we do with all that information? Well, for second generation antipsychotics, this is typically what we use in schizophrenia maintenance treatment because they do tend to be better tolerated and they have the lower risk of extrapyramidal symptoms. Unfortunately, we don't have any head-to-head efficacy or effectiveness studies of antipsychotics in psychotic disorders except for schizophrenia spectrum disorder. So we don't know specifically how much better or worse things are going to work in cases of schizoaffective disorders or other types of psychotic disorders. So, other than schizophrenia. So, the CATIE trials had been completed. And these CATIE stands for Clinical Antipsychotic Trials for Intervention Effectiveness. There are a whole bunch of publications based on these trials, and they really kind of shed light on a lot of questions that a lot of people had about antipsychotics in general. Some of the key take-home points are that all of the second-generation antipsychotics have similar effectiveness except for clozapine. What we know is that clozapine is better than other second-generation antipsychotics. It's the only antipsychotic that demonstrates lower suicide risk. So if you'll remember when I talked about lithium in the major depressive disorder lecture, lithium and clozapine are the only two psychoactive agents that actually lower suicide risk. And so that's definitely an important thing to remember. So lithium and clozapine are the only agents that have been proven to be anti-suicidal. Because of clozapine's adverse effects, it does have a REMS program, and its other poor tolerability issues do limit its wide use. And so even though we know that it's better than a lot of the other SGAs, we still keep it as sort of a maybe third or fourth line treatment, because we really want to make sure that somebody really needs it, to make sure that the benefits of it outweigh the risks. So rather than thinking about certain agents are more effective than other agents, because we know that that's not true other than clozapine, we tend to choose agents based on their side effect profiles. So you want to consider somebody's baseline metabolic profile, because second generation antipsychotics have a litany of metabolic adverse effects that the pre-lecture worksheet should have gone over in depth. So if somebody is already has coronary artery disease, has diabetes, has dyslipidemia, you really don't want to start them on an agent that's going to make all of those things worse, like olanzapine or clozapine. You also want to consider the other medications that they're on, because a lot of the antipsychotics will have drug interactions. And then other baseline comorbidities, kind of like what I just talked about. So another thing to consider when choosing an antipsychotic is whether or not you want to choose an antipsychotic that has a long-acting injectable option. You want to consider the long-acting injectables when there is risk for poor adherence to oral agents. So this might be because the person has poor insight into their illness, so they reject treatment. They feel like they don't really need treatment. They're not psychotic, they're not having symptoms, this is all normal. If they don't think anything's wrong with them, they're not likely to take a treatment to treat what's wrong with them. Other times people will stop taking the medications because of the adverse effects. Some of the patients will endorse that the hallucinations and delusions will basically kind of convince the patients to avoid taking any medications. Or if a patient has substance use disorder, then that definitely negatively impacts adherence. And then some patients might actually just request to be on a long-acting injectable because they don't want to take a medication by mouth every day. You also want to consider an optimal administration regimen, so whether or not somebody wants to come into a clinic every 2 weeks for an injection or every 4 weeks for an injection, because the different agents have different intervals at which they need to be administered. So there are certainly pros and cons of long-acting injectables. Pros, it does allow for easy adherence monitoring, because the person has to come into the clinic in order to get the injection, so you know always when they are actually getting their injections. They don't need to take a medication every day. It allows for regular contacts with medical staff, so it kind of enables better also like efficacy and symptom monitoring to make sure that somebody's actually responding to treatment. And that kind of goes into the next bullet. So it's easier to discriminate between non-adherence versus lack of response or a relapse. It reduces an overdose risk. So a lot of these medications can be fatal or deadly if taken in excess quantities. So you're less likely to see an overdose risk if a clinician is administering the medication as directed. And we tend to see more stable plasma concentration. So some of the agents have peaks and troughs when they're taken every day, and with the long-acting injectables, we don't tend to see those peaks and troughs. As for the cons, long-acting injectables take a longer time before an effective dose or steady state is achieved. Sometimes you have to overlap between, which is what the last bullet says, you'll have to overlap between the oral formulation until steady state is achieved. You also have less flexibility with dose adjustments. The long-acting injectables tend to be offered in pretty discrete dose intervals, and so you don't have all of that flexibility to really kind of increase by a little bit and see if anything happens. It's possible for patients to have injection site reactions, and it does require frequent visits with the medical staff. So while sometimes that's a positive thing because it allows the medical staff to more closely monitor the patient, it could be a negative thing on the patient's side of things because it just requires that they're into the clinic more often. So here's just an overview of the kind of approach that most of the time we'll take with schizophrenia treatment. We have two stage ones. So stage 1A is somebody who's completely treatment naive and they have had their first break or their first psychotic episode. So you basically start with any antipsychotic monotherapy except clozapine. So you could do first generation, second generation, anything. Typically people start with second generations, again, because of the possibility of continuing it into maintenance and the fact that second generation antipsychotics have less risk of extrapyramidal symptoms. Stage 1B would be like restarting treatment after a period without an antipsychotic. So this is somebody who's probably already been diagnosed with schizophrenia, who has gone a period of time without taking their medication. So in this case, you could also use any antipsychotic except clozapine, but at this point, it might be reasonable to consider avoiding one that was previously poorly tolerated or that yielded poor efficacy. So if the person's been on one and stopped taking it in the past, maybe avoid the one that they stopped taking before, if it was something that they stopped taking for a particular reason. So after that, if you've tried an antipsychotic and those didn't work, you're now into stage 2. So the patient had an inadequate clinical response with an antipsychotic used in stages 1A or B. So at this point, you can, again, try any antipsychotic monotherapy except clozapine, but an antipsychotic that wasn't used in stage 1A or 1B. So at this point, it's just trying a new antipsychotic. If the person is severely suicidal, you could consider clozapine. So this is when you can, because clozapine has the anti-suicidal properties, if the person is severely suicidal and they've already failed one agent, you could consider clozapine at this point. If that agent fails and you haven't tried clozapine yet, you then go into stage 3. So the patient has now had an inadequate clinical response to 2 appropriate antipsychotic trials. So appropriate means the dose was effective, the person was actually taking it, everything was fine except for the fact that they still had psychosis. So at this point, you would then start clozapine monotherapy. If clozapine monotherapy fails, you're now in stage 4. And at this point, we have very little evidence to show what happens to patients after they've failed clozapine. At this point, you can try a different antipsychotic monotherapy, or you could try to combine some types of antipsychotics or add something on top of clozapine. However, there's really little evidence to show what to do at this point. All along this whole pathway, you want to use or consider using a long-acting injectable for patients with poor adherence, or if they prefer to do a long-acting injectable. So we're back to Joe. At the last encounter, you suggested that Joe start taking his olanzapine at night if the sedation, to see if the sedation improves. You had asked Joe to go to the lab after his last visit, but he forgot, so you were not able to get any of his monitoring parameters. Joe returned 1 month later and had started to appear overweight. Joe reported the sedation did improve, but that he cannot stop himself from eating all day long. So now what do? Do you stop olanzapine and start aripiprazole? Do you stop olanzapine and start quetiapine? Do you continue olanzapine because the weight gain will resolve in another 1 to 3 months? Or do you stop olanzapine with no replacement because Joe's had good symptom control for 2 months, so further treatment is not necessary? Well, in this case, I would actually stop olanzapine and start aripiprazole. It does seem like the olanzapine is causing Joe to gain significant amounts of weight now. He's overweight, and so we really want to make sure that we're not making this any worse, especially because he's so young. Aripiprazole is an agent that is not expected to cause such significant weight gain, and so that would be a reasonable agent to go to next. I wouldn't do quetiapine because that's another agent that tends to cause pretty significant weight gain, a little bit less so than olanzapine, but pretty significant. I wouldn't continue the olanzapine, like I said before, because the weight gain really is probably not going to resolve. It's probably only going to get worse, and we wouldn't want to cause Joe to have all of those kinds of adverse effects starting when he's so young. And then we certainly would not stop antipsychotic treatment with no replacement because this is something that should be continued as lifelong therapy if Joe will permit it. So for monitoring, I want you guys to refer to the pre-lecture worksheets for the information on metabolic monitoring of the second generation antipsychotics and clozapine monitoring. So, and remember, just plan on remembering the stuff that I've asked you to fill in yourselves, as opposed to needing to memorize everything on all of those slides. So I've only just added in one other thing for this part of lecture, which is cardiac monitoring or ECG monitoring. So all of the second generation antipsychotics have demonstrated some level of QT prolongation, but the data is really conflicting as far as the relative risk of one agent versus another. There tends to be relatively higher risk with the following 5 agents. That's ziprasidone, quetiapine, risperidone, paliperidone, and iloperidone. We don't often see progression from QT prolongation into torsades de pointe, but you do want to be aware. If you do see, you should be monitoring QT, or at least do like a baseline EKG just to make sure, and then monitor as needed, basically with symptoms. But there really is no specific monitoring schedule recommended. Like I said, it's appropriate to obtain a baseline ECG and then repeat when concerned for increased cardiac risk. So if you add on another agent that is a QT prolonging agent, if the patient has coexisting cardiac risk factors, or the person starts demonstrating symptoms that might make you concerned for the person having cardiac issues. You'd certainly want to encourage frequent monitoring or discontinuation and switch to another agent if the QT or QTC escalates above 500 milliseconds. So now we're back to Joe again. At his last visit, his psychiatrist stopped olanzapine and started aripiprazole. Joe was also referred to a weight management program. So at baseline, this was when he first had the psychotic break and was first admitted to the hospital. He weighed 150 pounds. His blood pressure was normal, his A1C was normal, and his lipids looked fine. And then from his last visit, his weight has increased already to 200 pounds, which is a pretty significant increase in the first few months of treatment, although this tends to be quite common when people start olanzapine. His blood pressure has increased significantly, A1C has increased, lipids are not looking great anymore. Today he comes into the visit, you're able to get his weight, and he's lost 5 pounds. So it looks like things may be going in the right direction since switching to aripiprazole. So, also today, he says he's got improved energy and now reduced appetite, but now he feels some sort of intolerable restlessness. He says, I just can't sit still, I feel like I have to be moving all the time. He denies auditory and visual hallucinations, and he denies delusions. What would you do now? Would you start lorazepam for akathisia? Would you consider or continue aripiprazole, as Joe will build tolerance to the akathisia? Would you taper off aripiprazole and start lorazepam? Or would you taper off aripiprazole and start clozapine because Joe has now failed 2 antipsychotics? So in this situation, I would stop aripiprazole or taper off and then start lorazepam. I wouldn't start lorazepam for the akathisia because that's just, you don't want to have somebody need to continue on a benzodiazepine for a long period of time. People with schizophrenia are already at increased risk of developing substance use disorders. I wouldn't want to introduce or increase that risk any further by starting a benzo. And it's just something that you don't really want to have the person be dealing with for the foreseeable future. I wouldn't continue aripiprazole because you don't build tolerance to akathisia. It only tends to just stay that, what he says, intolerable. So option B is not appropriate. I also wouldn't taper off aripiprazole and start clozapine because actually both the olanzapine and the aripiprazole worked. He hasn't failed them. It's just that he hasn't been able to tolerate them. So this is when it's time to try a different option to see if he could tolerate another option. And so I thought that lorazepam might be a good option because it's another agent that is less likely to cause weight gain. It might cause akathisia as well, but akathisia is one that isn't... it's not as clearly explained about the likelihood of the different agents to cause it. So like I said, with olanzapine and quetiapine and clozapine, all of those are very likely to cause weight gain. Well, with akathisia, we don't quite have the same expectations. If one agent is likely to cause akathisia and the other one may or may not cause it, we don't know to expect that the other one is going to cause it for sure. So on to patient and caregiver education. So one thing you want to talk about with patients when starting on an antipsychotic is treatment adherence. You want to make sure the patient knows to attend all follow-up visits and really highlight the importance of attending all their follow-up visits. Also highlight the importance of presenting for all laboratory appointments, because we really do need to monitor labs to make sure that we aren't increasing the person's risk of a variety of other comorbidities that could happen just based on them being on an antipsychotic. For medication, you want to discuss strategies for improving adherence with oral meds. So set an alarm clock or a phone reminder. Pair medication administration with another daily activity. So some patients will keep their medications right next to their coffee pot because they make a pot of coffee every morning, and so that's something that helps them remember to take their medications. Using a pill box also can be helpful. If the person has difficulty taking their medications every single day, consider a long-acting injectable. Just remember that this does still require attendance at follow-up visits for every injection. Additional medication education points are things to consider with some of the meds have unique characteristics requiring extra focus. So you want to make sure that you highlight a few different things. Quetiapine is a medication that can be dosed multiple times a day. So while we often try to make sure that somebody only needs to take a medication like once a day at bedtime, quetiapine has a shorter half-life, and so oftentimes people need to take it maybe twice or 3 times a day. Ziprasidone, it needs to be taken with at least a 500-calorie meal for adequate absorption, and lorazepam needs to be taken with at least a 350-calorie meal for the same thing. So these two agents definitely need a significant amount of medication education to tell patients, what kinds of foods they should be eating and when they should be taking these medications with respect to their meals. All of the second-generation antipsychotics require routine metabolic monitoring. So that's weight, blood sugar, and lipids. And it's because all of them can cause weight gain. Even the ones that have on that big table that I had you guys fill out in the pre-lecture worksheets, even the ones that are less likely to cause metabolic adverse effects, it's still possible that they would cause metabolic adverse effects. And so we do the monitoring for all of the agents. Because it can cause these metabolic adverse effects, this does increase cardiovascular risk, and we want to try to mitigate that as much as possible. And then you also want to discuss the side effects that we see specific to individual medications. So with quetiapine, olanzapine, and clozapine, we do expect to see heavy sedation, and so just make sure to educate patients that that's something that they may want to look out for, and don't operate heavy machinery as they get used to the medication. Aripiprazole is one that kind of more commonly causes that akathisia or that inner restlessness, and so that's something they could look out for and make sure to let you know if they start experiencing it. And risperidone and paliperidone are more likely to cause gynecomastia because they have a little bit more potent dopamine blockade than a lot of the other second-generation agents, and so they're more likely to inhibit dopamine in the tuberoinfundibular dopamine tract, which would then increase prolactin release and cause gynecomastia. So another thing that you want to cover with patients is just to consider talking about therapeutic lifestyle changes. So even though these patients have schizophrenia and maybe their functioning is a bit lower than patients that you're used to seeing, it's still totally appropriate to cover some of the things that they could be doing in their life to reduce some of those metabolic side effects that happen. So for diet, just educating them to try to increase their intake of fruits and vegetables, maybe limiting high-fat and high-sugar foods, or try to eat in discrete meals rather than grazing. So specifically, the agents that are really bad at increasing metabolic risk, what they do is they increase the patient's appetite such that the patient kind of just wants to eat all day long, and it causes them to graze all day long. And so you want to tell them or try to educate them to eat in specific meals and to try to avoid snacking. Also exercise. So remembering to tell patients that any amount of increased activity counts and is valuable. Just try to aim for at least 30 minutes of activity most days of the week. Smoking cessation is important in reducing cardiovascular risk, so it's something to counsel patients on. However, we really need to consider what happens when people do decide to stop smoking, because it can have major effects on drug levels. So acenapine, clozapine, and olanzapine are all metabolized through cytochrome P450 1A2. And so that enzyme is the enzyme that is inhibited by tobacco cigarette smoke. And so when people smoke cigarettes, that enzyme is being induced. So 1A2 is induced by tobacco cigarette smoke. And so when 1A2 is induced, that causes the liver to kind of eat up those medications more quickly and more thoroughly. So acenapine, clozapine, and olanzapine are all at relatively lower levels in people who smoke. So if somebody decides to stop smoking, that can actually cause a life-threatening toxicity, because that induction goes away after a few days, and the person's 1A2 levels then kind of like get back to normal, and it causes a massive increase in the drug levels. And so this life-threatening toxicity, people have died, have had seizures on clozapine. It's definitely a concern for clozapine because of all of the adverse effects that clozapine has, but it can also be a significant concern for acenapine and olanzapine as well. So very, very important to educate patients and take some extra steps when talking about smoking cessation if they're considering it, as long as they're on antipsychotic treatment. And then also just educating patients to limit alcohol, because this can cause increased risk for a variety of things. So back to Joe. 1 year later, Joe is hospitalized again for return of bizarre behaviors and command auditory hallucinations. His parents state that until about 3 months ago, he was doing very well. On interview, Joe explains that he is not sick and he does not need medication. Joe is treated acutely with risperidone for a few days. What should be considered for his maintenance treatment? Should it be olanzapine because it worked well for him in the past? Should it be lorazepam because it was safe and effective for him as long as he takes it? Should it be clozapine because he's now failed 3 antipsychotics? Or should it be paliperidone long-acting injectable? So in this case, we wouldn't go back to olanzapine because it caused so much weight gain that we would expect that it would again cause significant weight gain. We wouldn't try lorazepam again because he stopped it for some reason before, and it's an oral medication. So if he really doesn't think he's going to take, or he doesn't need medication and he's not sick, it might be hard for him to be convinced to keep taking an oral medication. We wouldn't try clozapine because he actually hasn't failed 3 antipsychotics. All 3 antipsychotics seem to have actually worked quite well. It's just that side effects and adherence have limited their efficacy. So we could consider paliperidone long-acting injectable. Paliperidone is a prodrug of risperidone, so it actually is kind of a smooth transition to go from risperidone to the paliperidone long-acting injectable. Another question, we have Oscar. He's a 34-year-old male with history of schizoaffective disorder who's been taking risperidone 6 milligrams daily for the last 9 months. For the past month, he's been reporting that the FBI has been following him, and he hears voices telling him to commit suicide so that the FBI cannot follow him anymore. He was just admitted to the hospital for a suicide attempt. Which of the following medication changes should be made? Should you increase risperidone to 8 milligrams daily, because risperidone 6 milligrams daily is a subtherapeutic dose? Should you taper off risperidone, start olanzapine 15 milligrams daily because it is a more potent antipsychotic? Should you taper off risperidone and start clozapine because Oscar has failed 1 antipsychotic and is actively suicidal? Or should you taper off risperidone and start haloperidol because it is a less potent antipsychotic? So in this case, it would be pretty appropriate to start clozapine because he just had a suicide attempt and he has voices telling him to commit suicide. So he is actively suicidal and he failed 1 antipsychotic that he had been taking continuously. Risperidone 6 milligrams daily is a therapeutic dose, so it's not accurate to say that it's subtherapeutic, so answer A is incorrect. We wouldn't start, or the answer here for taper off risperidone and start olanzapine, that part might be okay, except for the fact that olanzapine is not actually a more potent antipsychotic, and in fact, risperidone is a bit more potent than olanzapine is. So answer B is not correct. And then answer D, start haloperidol because it's a less potent antipsychotic, is also incorrect because we know that haloperidol is a highly potent dopamine D2 receptor antagonist as a first-generation antipsychotic. So it makes sense to start clozapine. All right, one more question. Bailey is a 19-year-old male who was started on paliperidone 3 months ago after his first episode of acute psychosis. He presents to his outpatient psychiatrist today, reporting tenderness and pain of his breast tissue. So what's the medical term for this symptom? That is gynecomastia, and I messed up my animation, so I'm sorry about that. The medical term is gynecomastia. What medication change should Bailey's psychiatrist make? So I already have the answer highlighted here. That's to taper off paliperidone and start quetiapine. So in this case, the relatively potent D2 antagonism that is happening with paliperidone is causing the gynecomastia symptoms. And so what you want to do is try to get an agent that has much less potency at the D2 receptors. And so quetiapine is one of those agents that has, because it is the D2 antagonist with rapid dissociation, then you get much less dopamine D2 blockade, and you're much less likely to see a side effect like gynecomastia. So you wouldn't switch to risperidone, because if you remember that other question that we just talked about, paliperidone is a prodrug to risperidone, so they're basically the exact same thing. And because they're exactly the same thing, we would expect that both of them would cause gynecomastia. Switching from oral to IM paliperidone would not help. That would also continue the gynecomastia symptoms. And then you wouldn't want to taper off paliperidone and start fluphenazine, because fluphenazine is another highly potent first-generation antipsychotic, and so we would also expect to see gynecomastia symptoms there too. All right, that concludes this lecture. If you have any questions, like I said, please post them on Blackboard, and I'll plan to see all of you tomorrow for the 5th lecture, which is going to be on bipolar disorder. Thank you.